Assalamu alaikum to students. This is the sixth session of the wrist, hand, and finger sports injuries. In this session, we will talk about the different injuries of the hand and finger. We have discussed different injuries. We have discussed different both the traumatic and the overuse injuries of the wrist in different type of sports. So the hand and finger injuries, they are extremely very common among different sports. And majority of these majority of these problems, either they require minimal treatment or they require no treatment, but still they should not be ignored and they should be treated, as if they are left untreated, so they may lead to a very potential disability as well. Sometimes these treatments they may require the surgery. Otherwise, they may be simply treated with the conservative treatment, via different splinting, immobilization, and different rehabilitation exercises. In different sports, the finger injuries they are often neglected by the sportsmen, and they why they neglect they just think that these injuries they are not so serious and they will treat by themselves, so they just think that they will resolve spontaneously, but many times these they are very late for the treatment, and that's why when they came toward the treatment, it's too late for them. And that's why there may be some need of the creation of awareness among the sportsmen, among the athletes, regarding the importance of that early assessment and management, so that the long-term deformity and the functional impairment in these athletes and these sportsmen that should be avoided. During the history taking of the injuries in the hand and fingers during the sports, the most important thing is to the question which should be asked related to the mechanism of injury. Because if we are known to the we came into the that mechanism of injury, then it will give us a very important clues and information about the diagnosis. uh, that maybe during the history taking during that mechanism injury, that may be a direct severe blow, or that may be just a punching injury. A direct severe blow to the fingers that may result in a fracture, whereas a blow to the point of finger that may produce interphalangeal dislocation. Sometimes they may also cause some extensor tendon avulsion or the sprain of the different ligaments. Sometimes a punching injury, they also result in a fracture of the base of the first metacarpal to the neck of the other metacarpals, usually the fifth, which are known as the boxer fracture. And such injuries, they are very common in the boxing sports, in which the base of the different metacarpals, they may become fracture both transverse and that may fracture obliquely. Involvement of the flexed digitorum profundus, and most commonly to the fourth finger, that suggests that the person may have this problem when he is trying to grab the opponent's clothing while attempting the tackle. And such injuries, that avulsion of the flexed digitorum profundus, that is known as that jersey finger, and that is very common among different contact sports. Associated features such as the audible crack, degree of pain, and swelling, bruising, and loss of the function, they should also be noted during the history taking process of these injuries to the hand and fingers. So these are some of the causes, common causes, discommon causes of the both hand and finger pain. The common causes they are the metacarpal fracture, the phalanx fracture, dislocation of the proximal interphalangeal joint, the ulnar collateral ligament sprain, tear, and of the first MCP joint, sprain of the proximal interphalangeal joint, laceration, infection, and the subungual hematoma. Laceration means that simply open cut in the skin, and it may affect either the superficial layer, the dermis, or it may affect the deep tissues like the tendons, muscles, or the ligaments as well. Subungual hematoma, that is a medical term which is being used for that. injuries and hematoma inside beneath that nail. So that's simply known as the subungual hematoma, bleeding inside the nails, nail bed of the toes as well as of the fingers. The other fracture they are very less common. They are the Bennett fracture. Bennett fracture. This is the fracture of the post metacarpal. We will discuss in detail about that Bennett fracture in the upcoming slide. The other less common causes of the hand and wrist, hand and finger pain, they are the dislocation of the metacarpal phalangeal joint, dislocation of the distal interphalangeal joint, the radial collateral ligament sprain, and specifically of the first metacarpal phalangeal joint, the sprain of the distal interphalangeal joint, the mallet finger, which may be both involving the soft tissue as well as the avulsion injury as well. This is the that rupture of that extensor mechanism on the dorsal surface of the fingers, that mallet finger. The stress fracture and the glomus tumor. A glomus tumor, these are the benign tumors of the glomus body, and glomus body, they are the specific center in the human skin, and they are the thermostat, they are controlling that temperature. So this is that specific area where there is anastomosis, or where there is a mixing of the arterial blood with that venous blood. So this is that specific area which control the temperature, and those specific cells, they are known as the glomus cell, and the tumor of these cells, that is known as the glomus tumor. This is a benign tumor. Some problems which should not be missed while assessing the hand and finger in the history. This is the potential infection, for example, any human bite or any other thing, as well as the avulsion of the long flexor tendon. So these were just the list of the different problems, different injuries, which are common or less common, and they may cause the pain in the hand and the fingers. They will be discussed briefly in the upcoming slides. During the history, palpation that should be carefully conducted, and the bones and the soft tissue of the hand and fingers, that should be palpated very carefully, and they all should be checked for any tenderness. As if there is tenderness, so they both indicate that there may be some fracture, there may be some tendinopathy, or maybe there, and which indicates some sprain as well. So the joint should be examined to determine inactivity and that passive range of motion and stability of those joints. Stability should be tested both in interior posterior direction as well as in the radial deviation, just to assess the integrity of the different collateral ligaments of the fingers. The cause of any loss of active range of motion should be carefully assessed and not presumed to be due to swelling. Normal range of motion for the second to fifth digit is approximately 80 degree of flexion at the distal interphalangeal joint, and then 100% of flexion at the proximal interphalangeal joint, and more proximally at the metacarpal phalangeal joint. The range of flexion, it is almost 90 degree, and we can just, if we do that flexion, we can just make fist. So there we can see the flexion, the degree of flexion of different joints. This is the DAP, PAP, or the MCP. A common injury site that can be overlooked in the ulnar plates, a thick fibrocartilaginous tissue that reinforce the phalangeal joints on the palmar or ulnar surface. The most important benefit and advantage of this ulnar plate is that it increases the congruency on the ulnar surface, and it also prevents the impingement of the different tendons inside these joints, which is the PAP and DAP, and they are present there. So these two benefits there, and that's why the presence of this ulnar plate is very necessary. And why they are known as the ulnar plate? Because they are lacking on the dorsal surface. As when we are going to flex at the DAP or the PAP, these are the ulnar plate which prevent the impingement or the entrapment of this tendon inside the joint. And not only because it prevent that entrapment and impingement of tendons inside that joint surface. It also increased the congruency of these PIP and DAP as well. The extensor tendons of the hand, they are often divided into 6 compartments, and we have discussed in the previous wrist injuries when we were discussing the intersection syndromes. One is that proximal intersection, the other is the distal intersection. So here we discussed that that the proximal intersection, that is the intersection between the first and second compartment. Similarly, the distal intersection, this is between the second and the third compartment. So all these are the different compartments. So the total extensors, these were the story about the extensor on the radial side, the intersection. But the total extensor tendons on the hand, which is present on the dorsal surface, they have been divided into 6 compartments. At the wrist, on the dorsal side of the hand, the tendons, they are encased in synovial sheath as they pass under the extensor retinaculum. Uh, when palpating the most radial compartment, the compartment 1, which is the abductor pollicis longus and the extensor pollicis brevis, these both are present inside a sheath, and the inflammation of their sheath, that is, which is actually tenosynovitis, that specific tenosynovitis of this abductor pollicis longus or the extensor brevis, that is the Dickwer vein tenosynovitis, are simply known as the Dickwer vein disease. The Duchenne disease is simply, we can say that it is the disease, or it is the injury, or it is the problem related to the compartment 1, and which tendons, they are the part of this compartment. This is the abductor pollicis longus and the extensor pollicis brevis, which are the abductor of the thumb and the extensor of the thumb as well. The next tendon, which is the extensor pollicis longus, that is that third compartment, and between which make the contribution and which may involve in the distal intersection. The listed tubercle, a small tubercle which is present on the dorsal surface of the distal radial end. The extensor pollicis longus, which we discussed, that it is the third compartment, the extensor pollicis longus, that angle sharply around that bony prominence, and sometimes during the sports, this prominences, this listed tubercle, they may damage this tendon, and even it may rupture this as well. Whenever there is some serious injury, there is some a very high impact fracture to the wrist bones. The anatomical snub works, this is composed of the extensor pollicis longus and brevis and the abductor pollicis longus. This anatomical snub works, this is actually a triangular area, and this area is present between the 2 compartments. The one compartment, which is the first compartment, this is the extensor pollicis brevis and the abductor pollicis longus, and the next compartment, which is the third compartment, which is the extensor pollicis longus. So we can say that this anatomical snub box is present between the 2 compartments, the 1 and the third compartment, which are the one of the 2 compartments out of 6 extensor compartment. This anatomical snub box, that can be palpated, and that can be very easily seen on the radial side, and the floor of this ectodermal snub box, this is made by the scaphoid and that lunate, and specifically the scaphoid. So whenever there is fracture, as we discussed previously, it is fracture of the scaphoid. So this anatomical snub box, there will be very tenderness, it will be very tender, there will be high tenderness to the if there is palpation on the anatomical snub box. The floor of the snub box, this is the carpometacarpal joint of the thumb, and that floor is being shared by this carpometacarpal joint as well as the scaphoid and the as well. Clinically, this is a significant region for several reasons. Tenderness messages the scaphoid fracture. If there is any tenderness on the this anatomic snub box, that indicate there may be a fracture to the scaphoid, as scaphoid is present in the floor of that snub box. The deep branch of the radial artery that passes through, as well as the superficial branch of the radial nerve. Consequently, if a cast or splint is applied too tightly, it can lead to the numbness of the thumb, and that such patients with this condition, and they will be unable to wear any tight band around their wrist. They will be unable to wear any tight watches, because these watches and these bands, they will put pressure on these structures, which will create that numbness in the thumb. The examination of the hand and fingers that involve different steps in which include that different observation and sensation, as well as the active movement and special test. During the observation and sensation, they are being tested as for the wrist, and some special notes should be made on the head of the hand arches and any deformities at the proximal or the distal interphalangeal joint. Hand arches, there are two types, the longitudinal arches and the transverse arches. And the transverse arches, they are being then two in number, the distal and the proximal. So total arches of that hand, they are three in number. If we talk about the arches of the hand, so there are two categories. One is the bony arches, the other is that arterial arch, or we can say the palmar arches of the radial artery. So one is that vascular arches, the other is that the bony arches. So the bony arches, which we talked about, that transverse and longitudinal, these are the bony arches which are formed by the concavity of the different bones on that in the wrist and the head. Similarly, the active movements of all the fingers of all joint, including the MCP, including the PIP and DIP, they should be checked for the flexion, extension, abduction, as well as the adduction. The active movements of the thumbs, they are much different from the other fingers, and that's why they should be checked, and they should be considered as separately. There is a flexion and extension of this thumb, which are much different from the other fingers. The palmar abduction, that is the movements of that thumb towards the palm of the hand. The palmar abduction is moving the thumb away from the palm, and the palmar adduction is simply moving that thumb towards the palm surface. And a position when there is bringing together the small finger, the pinky, and the thumb. Resisted movements of the different tendons, they should be conducted for the different muscles, including the extensors muscles and the two flexor digitorum profundus and flexor digitorum superficialis, and the PIP and the DIP joints. A special test that should be conducted for the ulnar collateral ligament of the first MCP joint, as well as the that interphalangeal joints for the collateral ligaments. The resisted movements, which are for the profundus, there should be check the flexion at the DIP joint, and for the superficialis, and the movements resistive movement, that should be checked at the proximal interphalangeal joints. So this is the that hand at rest when there is no such movement. This is the hand with the clenched fist. These are the knuckles, which are actually the head of the metacarpals. These are the metacarpals. So the knuckles here, we can see these are made by the head of the different metacarpals. This is the fifth, this is the fourth, this is the third, and this is the second metacarpal. These are then the phalanges, the proximal phalanges, and this is the PIP, which is the proximal interphalangeal joint. This is the thumb movement, the palmar abduction, when the thumb is away from that palm of the hand. And if we bring that thumb towards that palm, inside to the palm, then it will be the adduction of the palmar adduction of the thumb. This is the position when the pinky, the small finger, and the thumb, they are bring close together and to touch each other. This is the known as the opposition. So this is that tendon integrity, which is for the flexor digitorum profundus. The patient flexes the DIP joint with the PIP joint held in extension. Similarly, for the integrity of the flexor digitorum superficialis, The patient will flex the PIP joint, whether the other DIP joint held an extension, which is opposite of the previous one for the flexor digitorum profundus. This is the special test, which is for the ulnar collateral ligament of thumb, as is tested at the 10 degree of flexion at the post MCP joint, and the integrity of that ulnar collateral ligament that is checked. The therapist will apply pressure on here at that area, while at the other, the index finger of the other hand, they will just apply pressure on that one. So they will be checking and assessing the integrity of this ulnar collateral ligament. Different investigation that can be assessed used in the assessment for the evaluation of different injuries, and specifically the radiographs. They are very effective in giving that clues during the fractures of the hand and wrist, as well as in the fingers. But if there is any soft tissue injuries, then the radiograph, the X-rays, as well as the CT scan, they may not help in that way. So then MRI is the best choice, and this is the gold standard for the identification of the different small the musculoskeletal injuries. So routine radiographs of the hand, they include the PA view as well as the oblique and the lateral views. All traumatic fingers injuries, they should be X-rayed, and not only just prior to the injury, but after the reduction, they should be X-rayed regularly, weekly basis, on the weekly basis, that either there is reduction, that successful reduction of the different fingers or not. Ideally, when there is dislocation, there need to be radiograph before the reduction and to exclude fracture, and as well as after the reduction to confirm either there is relocation or not. Even after when the pre-reduction radiograph, they are not performed because the reduction mostly they occur on the field side. But after when the game, after that end of the sport, there should be uh, post-reduction films just to check any involvement of that, just any successful reduction of these dislocations. That care should be taken with lateral views to isolate the affected finger to avoid any overlapping of the different bones. The treatment of the hand injuries, mostly they just most of the cases they simply require rest, as well as some mobilization as well at the next stages, and then the strengthening of the different tendons. So the functional hand that requires mobility as well as stability, that sensitivity and the freedom from the pain. Conservative rehabilitation that is essential to regain mobility and long-term freedom from the pain, and the treatment and rehabilitation of the hand is very complex, and that should be isolated, and they should be specific for each and every injury. Inflammation and swelling, they are obvious in the hand and fingers. If they are acute, they might be treated with the price, which is that prevention for the further injury. That means splinting or something else. That is mean wrist immobilization and icing, and this icing will help very much in the reduction of that swelling as well as in the pain as well. And at least the icing should be conducted in the initial 2 days, and after 2 days if there is no swelling, so then there may be discontinuation of the icing. During the inflammatory phase, the therapist must aim to reduce edema and monitor progress by the sign of redness, heat, and the increased pain. During the regenerative phase, characterized by the proliferation of the scar tissue, the therapist can use the supportive splint and active exercises to maintain the range of motion. There are four phases of the healing, and this regenerative phase, this is actually the third phase, and because of the that proliferation of that scar tissue, this regenerative phase, this is also known as the proliferative phase. The total phases, the number of phases, there are four. The first phase, this is the hemostasis phase, which is sometimes also known as the bleeding phase. The second phase, this is the which we discussed in the previous slide. This is the inflammatory phase. This inflammatory phase, this is also known as the defensive phase. The second phase, the third phase, this is the regenerative phase, or the that proliferation phase. And the last phase of this healing, this is remodeling phase, or we can also term as the maturation phase, is built to this fourth one. So during that regenerative phase in which there is a proliferation, the therapist can use supportive splint and active exercises to maintain that range of motion. During that last, which is the fourth phase of the healing, this is the remodeling, the maturation, in which there is appropriate to use the dynamic and serial sprint and active assist exercises in addition to heat stretching and to electrotherapeutic modalities. Dynamic and serial sprints, they are specific type of sprints in which there is which allows some sort of movements, while the supportive sprints, they are usually the immobilization sprints. They are also known as that static sprint. A control of edema that can be achieved by different methods, which including through that splinting, compression, icing, elevation, as well as some electrotherapeutic modalities, specifically the ultrasound. A therapeutic ultrasound that is very effective in controlling the swelling and that edema in the different soft tissue injuries. Splinting then need to be intrinsic plus position with the wrist and at least 30 degrees of the dorsiflexion, while the MCP joints, they are fixed to 70 degrees, and the PIP joints that extend to the 0 degree, they can be kept at neutral with the thumb abducted. And this is the specific position of the different joints when there is need of any casting to the injuries of the hand and fingers. Splint they are periodically removed to allow exercises, as well as fist making exercises. They are used to maintain the joint movement and to help the removal and the decrease in that intensity of the edema. During exercises, the hand should be elevated, and this through this, there that will also help in the reduction of the edema as well. So these are the some of the tendon gliding exercises. Here So these are the tendon gliding exercises, and they are very important. They are must to the protocol when there is injury to the hands as well as in the other joints of the hand. So this is the straight hand. This is the hook fist. This is the full fist, and this is the straight fist. When there is, we can see that the knuckles, they're just going really straight and downward, while there is, this is the full fist, uh, there is the hook fist, and this is the straight hand. All these exercises and again repetition of these exercises, these are known as the tendon gliding exercises. So these are the tendon gliding exercises, which are the that a repetition of these exercises that should be needed. So compression in the hand, they be achieved with a number of compression gloves, as well as they can be achieved by using a Coban elastic bandage, and the size of that Coban elastic bandage, different sizes they are available, and 1 inch size, or we can say that the 2.5 centimeter size, that is more appropriate for fingers. So if we look at the extreme right, this is 1 inch that Coban elastic bandage, and that is more appropriate for the fingers. This is also another version of this Coban elastic bandage, which is 4 inches in diameter. Coban, that simple mean CO, it's from the cohesive, and BAN is from the bandage. So this is just cohesive bandage, and this specific Coban elastic bandage or that cohesive bandage that is used for in different conditions when there is edema. So they help in the reduction of the edema at the hand and the wrist, as well as in the fingers and the arm. The 4 inch that is usually used in controlling the edema of the when there is edema in the lower limb or when there is edema in the large areas. And if appropriate, active tendon gliding, which we discussed in the previous slide, these are the tendon gliding exercises, as well as the active range of motion and the passive range of motion and the assisted range of motion exercises, in combination with elevation that can assist in the reduction of the swelling. Electrotherapeutic modalities, as we discussed, that is the therapeutic ultrasound can help in the reduction of that edema and swelling. Different exercises that can be used by the therapist to treat that patient from injuries in the hand and fingers. And these exercises may be that may range from the active exercises to the active assisted, or it may lead to the progressive, which is that resisted exercises. If there is tendon lacerations and or there is a rupture to the tendon, so they are generally treated by protocols which may be determined by the surgical technique as well as the technique which is being uh, guided and which is being recommended by the treating surgeon. A full description of the protocol that is beyond of this lecture. We can't explain that detailed protocol for each and every injury because we have listed a number of injuries and all of them that will be discussed briefly in the upcoming slides. So these are the some of the exercises in the bottom, which are the registered abduction, the registered flexion, and that pulling paper apart and then tracking that tennis ball. Specifically, this exercise is a very good one, which is that tracing the tennis ball, because during the tracing on the tennis ball surface, there is the extended finger as being bended at every joint at both the PIP as well as at the DIP. So initially, when the patient trace his finger over the tennis ball surface, so they will be flexion at the proximal interphalangeal joint, and they will be extension at the distal interphalangeal joint. But if he or she continue the tracing more, they will be. He can also bring that fingertip towards their palm, so they will be again flexion of the distal interphalangeal joint as well. Some other exercises for the injuries, they include that blocking exercises in which we can see on the extreme left on the top when there is blocking up movements. As we know that there are small joints in the hand, and when we are moving, when we are mobilizing some joints, so there may be movements at the other joint as well. So blocking exercises or blocking extension, that simply mean to prevent the movement in some joints and to allowing movements at the some other joints. This is actually known as the blocking exercises. Like we can see that on that extreme left side on the top, that the patient is doing extension and that is blocking extension. It means that the extension is being done in all those fingers. So there is prevention of that flexion at the PIP. So the blocking exercise which isolate the muscle being used by the embolizing appropriate joints with the other hand, and some other exercises like the which are known as the tendon gliding exercises. They can be also termed as the composite flexion exercises, the extension exercises, the active assisted exercises, the resistance exercises. They are different exercises in which the patient takes a joint through the full range of motion, and then the therapist assists in gaining slightly greater range when he or she applied some over pressure over it. So these are some of the exercises which are the active joint blocking exercises, as we can see here from these images. These are on the right side. Again, these are some of the exercises which the patient, the therapist may prescribe for your patient. Tapping and splinting during the injuries of that fingers, that is very important and very necessary, and most commonly the method used is the body tapping. Body tapping is a specific technique in which the injured finger that is bandaged together with the neighborhood healthy finger, as we can see in the picture on the top on the right side of the slide. If we look at here, there are two fingers and they are being bandaged together with the two sides. Among them, one would be the normal, the healthy, and the other will be the injured. So this bandaging of two fingers together, the benefit is that healthy finger that will encourage the movement and the healing, and the other injured one. So that is one of them, and specifically this will also add some stability. If we left this injured alone in the sprinting, so there may be a re-injury to this fingers, as the pressure will be unable to use this finger. So that's why if we bandage the healthy one along with the injured one, then he will use the both fingers together, and hence the healthy one will encourage and will provide that stability to the injured one, and will help in the quick recovery and the quick healing from the injury. That unjoined digit provides additional stability and encourage full range of motion. In the acute phase of injury, static splints they are used to reduce edema. Dynamic splints that can also be used in the repair phase of the injury to provide some of the force along joints and encourage increased range of motion. We have discussed about the static splint and the dynamic splint previously. With the dynamic sprinting, the sprint should be worn with less tension for a longer period. So these are the difference in general discussion of the general classification of the sprints, which can be used in the condition of the wrist and hand. So these are the characteristic of the static orthosis or the static sprint, and these are the dynamic orthosis or the dynamic sprints. In the static orthosis, they do not permit any motion, and that's why they are known as the static, and they are referred as to the resting splints or the positional splints. They are commonly fabricated from the low temperature thermoplastic material, but if a permanent orthosis is required high temperature, that copolymer plastic, they can also be used for such purpose. The dynamic orthosis, they are opposite of the static orthosis, which is they permit some movement, unlike the static sprints and orthosis. They are sprints that provide a dynamic force, and they are generally using energy storing material like the rubber bands, the springs, steel, the wind curve, or any plastic with some memory. So this is the body taping, in which the two fingers they have been bandaged and taped together. The one is the healthy, the other is the injured one. This is the dynamic flexor extension split. As we can see here in this, that the patient is can flex his or her finger, but if he is not flexing, his finger will be an extension anytime. So let's start from the different injuries, and these injuries will be discussed from the first metacarpal, and then we will shift towards the other metacarpals as well. The fracture of the base of the first metacarpal and the mechanism of injury of this fracture. This is when a punch is connected and with it's hitting a hard object. That hard object that may be the head of the opponent player, or as well as it may be a fall on the abducted thumb. This fracture, which is at the base of the first metacarpal, there may be divided into two types. The intra-articular as well as the extra-articular. Sometimes there may be three types of classification. This is the extra-articular, the partial intra-articular, and the complete intra-articular. Or we can say that intra-articular, there can be partial or there can be complete. So the extra-articular, again, it is divided into two types that may be oblique in nature, which is known as the extra-articular oblique fracture, or it may be transverse, which is known as the extra-articular transverse fracture. And this extra-articular transverse fracture of the base of the first metacarpal, this is about 1 centimeter, or we can say that point half inch, 0.5 or half inch distal to the joint, and that's why it is far away from the joint surface, and does not involve the joint surface. It is known and considered as the extra-articular. It means outside the joint or outside the articular surface. The intra-articular joints, in which those fractures to the base of the metacarpal, which involve the articular surface, and that is the one is known as the Bennett fracture. The other is Brunaldo fracture. The Bennett fracture, this is when there is partial interarticular, and this is actually a dislocation of the first metacarpal, carpal metacarpal joint as well. While when there is complete interarticular in nature, this is known as the Ronaldo fracture. The Ronaldo fracture, that may be a Y-shaped fracture or that may be a T-shaped fracture. Both shapes they are considered as the Ronaldo fracture. So this is how we can divide the base of the uh, as first metacarpal into two: the intra-articular, the extra-articular. If this injury is in the adolescents or if it's in the children which are in the still they are immature skeleton, they have immature skeleton, so then there may be epiphyseal as well. And according to the Salt and Harris classification, we can divide the epiphyseal fracture into five types. The type 2, the type 1, when it is parallel, we can say that transverse fracture and parallel to the epiphysis, then it is known as the type 1. The type 2, which is when the fracture that is above that epiphysis, that is known as the type 2. And type 3, when the fracture is below that epiphysis, that is type 3. And when both the fracture is present on the both ends, that distal and proximal of that epiphysis, then it is known as the type 4. And when there is narrowing and when there is diminishing of that epiphysis, that growth plate, then it will be known as the type 5. And usually such injuries, the type 5 injuries, they will be appear on the X-ray and the radiograph as they will be narrowing up that joint space, which is actually that growth plate space, because there will be diminishment of such growth plate. So as we can see here, the fracture is just above that epiphysis. So according to the Salt and Harris, this is the type 2 epiphyseal injury. This is also, if we look at the, it is far away, it is distal to the articular surface. So that's why it is also known as the extra articular. The other two, if we look at that shape, the structure of that nature of that fracture, it is oblique in nature, the other is transverse. So all these epiphyseal separation, that oblique and transverse, they are far away and that does not involve the articular surface, so they are known as the extra articular. On the other hand, if we look at the, when a small fragment on one side, that may be to the ulnar side or radius side, if there is separation of that fragment on one side, then it will be known as the Bennett fracture, and it is known as partial articular, as some part of that is involved and some it is not present on the other side. On the other hand, if we look at the Ronaldo fracture, where the fracture is from both sides, it is like a Y shape, then it is considered as a complete articular. So we can intra-articular, we can consider the Bennett and the Ronaldo both fracture as intra-articular, while the transverse, oblique, and the epiphyseal injury we can consider and term as the extra-articular fracture to the base of the first metacarpal. So the transverse fracture that is near the base of the first metacarpal results in the thumb, and when that is lying flexed across the palm. The reduction of this fracture that involves extension of the distal segment of the metacarpal, as well as this fracture that can be immobilized in a short arm speaker cast as well. The Bennett fracture, which is that partial intra-articular fracture, that is the dislocation of the first carpal metacarpal joint occur as a result of the axial compression. And that axial compression mean load parallel to the long axis of the bone when the first metacarpal is driven proximally shearing of its base. So this is the radiographs. These are the radiographs of the three fractures: the Bennett fracture, Ronaldo fracture, and the transverse fracture. If you look at on the left side, this is the healing transverse fracture. In the red arrow, this is indicated to that fracture. If we look at the other side, the Bennett fracture, the middle radiograph, here we can see that a small fragment is being separated on that one side. If we look at the other side, I mean, there is complete involvement in the that articular surface. This is the Ronaldo fracture. The red arrow, that my wrinkle arrow, that's indicating to the site of that fracture. So these all are the different types and examples and radiographs of the fracture of the base of the first metacarpal. The other metacarpal that can be fractured specifically in the sports of boxing, and the same mechanism that is being for them as we discussed previously for the first metacarpal. These fracture specifically the fracture in the fourth and the fifth one, which are the two most ulnar side metacarpal. They are very common among the boxing sport, and that's why fracture of the fourth and the fifth metacarpal they can be referred, they can be termed as a boxer fracture in the literature. This boxer fracture, this is usually accompanied by the considerable deformity in the flexion and the of the distal fragment. However, this deformity that result in the surprisingly little functional disability in the athletes. This is that one rule that when the meta and during that metacarpal fracture from second to fourth, second to fifth, the more proximal the fracture is, the more the knuckle will drop. If we look at here, uh, this is the head of the metacarpal. Um, this is the base of that metacarpal. So more the proximal it is, more the knuckle will drop. If it is distal, it is more distance, it will drop little. So it means more the proximal the fracture, like here, the knuckle will more the knuckle will drop, and more the distal the fracture is, the less the knuckle will drop. Another thing, the difference between the second and fifth and third and fourth metacarpal fracture is that, as compared to the third and fourth, the spiral fracture in the second and fifth one is unstable as compared to the middle two, which is the third and fourth. And the reason behind that is, if we look at the head of these metacarpals, this is these are all the heads of the metacarp, and these are the base of the proximal phalanges. So these heads, which make the knuckles when we make a fist, um, when we are making someone giving a punch, so the knuckle which are made, these are the heads of these metacarpal, sorry. So these metacarpal heads, they are connected to both sides by strong ligament, which is known as the deep transverse metacarpal ligament. And if we look at the third and fourth, both the sides and the ulnar and radial side, both they are connected by these ligament. This is the deep transverse ligament. But if we look at the second and the fifth one, they are connected only the one side, the inner side of these second and fifth metacarpal, while the outer side of the both second and the fifth metacarpal, that is not connected by such strong deep transverse metacarpal ligament. And that's why the spiral fracture is there is spiral fracture. These two also have this spiral fracture. This is also spiral fracture. So if we look at the spiral fracture of the second and fifth, they are more unstable as compared to these second, the third and the fourth. Uh, these were the fracture of the metacarpal, the first metacarpal, and then the fracture of the second two, the fifth metacarpal fracture, which are simply known as the Boxer fracture. Now, the fracture of the phalanges, and specifically the fracture, initially we discussed the fracture of the proximal phalanx, and then we will just go towards the fracture of the middle and the distal phalanx as well. So fracture of that proximal phalanx, they may lead to the functional impairment due to that extensor and flexor tendon coming into contact with that callus and exposed bone. Callus mean this is something hardening which can appear as a bulb on the skin, which can be appear as a knot in the skin. This is a hard tissue that is known as the callus. They control and reduce the fracture. And during the surgery, the under the rim block, the MCP joint should be flexed to 70 degree. A rim block is actually, it is a circumferential ring of local anesthetic solution which is used to block the nerves of the digit for the purpose of that minor surgery. And we can see here there are two small nerves in the this is the cross section of the finger. These are the vessels. These are the two digital dorsal digital nerves and the palmar digital nerves. These group of nerves and that are being blocked by that local anesthetic solution. And this is actually because there is that anesthetic solution is being used to block the complete in circular fashion. Thereby, this is known as that the ring block. These are the different sites of the injections. One is here, there is the injection site, and this is the another site of the injection where, and through these local anesthetic injection in these areas, that finger there will be blocked for such sensation, and this is necessary for that regional minor, which used for regional anesthesia during that minor surgery of the fingers. The PAP joint, the proximal interphalangeal joint, that is then flexed and longitudinal traction is applied and line with the shaft of the distal fragment to oppose the fracture. The fracture after that is immobilized with the wrist slightly extended and at 70 of flexion of the MCP joints. These fractures they require weekly radiograph just to ensure, just to confirm that there is no such movement between these fracture and the healing that is going is normal. If there is need of further stability, there may be a need and requirement of that body tapping, which we discussed previously when the healthy fracture is being tapped together with the injured one. The splint is removed after 3 to 4 hours, while that body tapping that will be continued after those 1 month, which is the 3 to 4 weeks after the injury or fracture. The unstable fracture sometimes that require the surgical referral as well in a very hurry, that is in urgent when it is unstable. The fracture to the middle phalanx, they are usually oblique or they can be transverse. These injuries, these fractures as compared to the others injuries, they heal very slowly, and the center slip of the extensor tendon that is attached to the dorsally to the base of the bone, and the flexor digitorum inserts on the other surface more distally. If we look at this image, they are talking about this one. If we look at these are these extensors mechanism, which is actually that extensor tendon that is attached on to the uh, base of this middle phalanx. But if we look at that flexor tendon, which is that flexum digitorum, and that insert distal as compared to the that attachment of that extensor tendon. So if there is injury, which is and this fracture is proximal to the attachment of this insertion of this flexor tendon, then there will be flexion of this fracture. But if the injury, the fracture is distal to the insertion of that flexor digitorum tendon, then the proximal area, the proximal to the fracture to the proximal area, the proximal point, the proximal part of that middle phalanx to the fracture that will flex, while the distal portion of that middle phalanx that will extend. So if you look at here, the fracture which are distal to the flexor tendon, that is they are talking about this one, attachment to show flexion of the proximal fragment and extension of the distal fragment. This is the extension of the distal fragment or the distal part of that middle phalanx, and the proximal to the fracture, that part is being flexed. So this is that mechanism that the injury, this is fracture to the proximal phalanx, and both the tendon, the extensor tendon, as well as the flexor digitorum that is being attached to the middle. So there is no such mechanism, but this proximal middle phalanx fracture or the distal middle phalanx, their fractures they can be described in these 2 points. And if there is proximal to that tendon attachment, and this is distal to that tendon attachment. This is the spiral fracture of the second, we can say that the middle phalanx of the that second ray. Stable fractures, they can be treated by simply immobilization and splinting, while the unstable fractures, or we can say that interarticular fractures, when they involve more than 25% of that proximal interphalangeal joint surface, they require that open reduction as well as the internal fixation. While the stable fractures, they are immobilized in a splint for the 3 weeks and a 70 degree of the metacarpophalangeal joint flexion and that extension of that proximal interphalangeal joint. Sorry, the flexion of that zero flexion of the PIP flexion, which means that will be straight, that will be extended. When the splint is removed, some different exercises like the active range of motion exercises, active assisted range of motion exercises, that should be initiated to the athlete. The older plate avulsion fractures, they can occur at the proximal interphalangeal joint following a hyperextension injury. And these injuries, they are very common and usually they are ignored just because of that unawareness of that potential consequences of these injuries to the athletes. At present, non-randomized controlled trials, they have compared early mobilization with the splinting and found that mobilization has led to good functional outcomes. The injury to the distal phalanx fracture, they usually, the mechanism of these injuries usually there's crushing injuries, such as that jamming of these fingers between a fast moving ball or a stick or a bat. Usually these are non-displaced injuries, and splint or compression dressing, they're usually used, and they will provide some adequate treatment for these non-displaced fractures. During these fractures, if there is too much pain, mostly this pain, these high intense pain, they are associated with that bleeding inside that nails of these fingers, that bleeding inside under the surface of that nail bed, so which is actually known as the subungual hematoma. So the mostly in these distal filling fracture, the subungual hematoma is very common, and the high intense pain is usually because of these hematoma under that nail bed. Significant subungual hematoma that requires nail bed excision. Excision means the surgical removal, as the nail bed is often disrupted. If we look at here, these are the two. The This is the middle finger, this is the ring finger, and the distal um, phalanx of both the fingers, they have been fractured. If we look at here, the fracture at the distal phalanx of the middle finger, this is more proximal than the other one in the distal phalanx of the ring finger, that has been fractured at the more distal in the tip. And that's why in this case, if there is in the ring finger, there will be more subungual hematoma. As if we look at this, the fracture may be like here. So this there is, if we look at the color of this nail, this is look blackish in color, and this is because that the bleeding inside that nail bed. And here we can also see that swelling as well. So this is actually subungual hematoma, which is mostly associated with the high intense pain of these non-displaced fractures. After the fractures, there may be some injuries which are the dislocation of the metacarpophalangeal joints, but as compared to the fractures, these dislocations, they are uncommon, and these are, if they are present, mostly they occur in the two fingers which are neighborhood present with the neighborhood of each other. This is the index finger and the thumb. Sometimes these dislocations, they can be also referred and termed as the irreducible dislocation. And the reason behind this terminology is because the metacarpal head is pushed through that polar plate of that metacarpophalangeal joint, and then this is being caught between that lumbrical and the long flexor tendon with a buttonholing effect. That lumbricals are specific intrinsic muscles which are present there in the hand. Thus, if there is any suspicion of this injury, um, the examination revealed that hyperextension is involved at the MCP joint with some unnervation of the finger that is overlapping the adjacent finger. A dislocation of the proximal interphalangeal joint. This PIP joint dislocation. These are the most common hand dislocation. They usually result from a hyperextension stress with some degree of longitudinal compression, such as may occur in the different ball sports, specifically in the basketball and as well as the American football. This may produce disruption of both the ulnar palate and at least one collateral ligament. A reduction often occurs one or beside the playing area. A reduction is maintained in a splint that allows that full proximal interphalangeal flexion, but block the final 30 degree of the PIP extension for 3 weeks. If this injury is left untreated, this hyperextension deformity and instability may develop. These are the images, the radiographs of the dislocation of the proximal interphalangeal joint. Both they are, if we look at here, this is the that pinky, which is that joint is dislocated at the proximal interphalangeal joint. This is the fifth metacarpal. This is the uh, proximal phalanx. This is the middle phalanx, and this is the PAP. On the other side, again, this is that pinky, where that PIP joint has been dislocated. And this is actually that reduction, close reduction of simple. First, the therapist, they will just provide some traction to the middle phalanx, and then an ulnar pressure will be provided, and hence it will uh, make it introduction and make it on its own place. After that, the splinting they should be prescribed and should be worn by the patient after the dislocation. This dorsal block splint allows friction, but that stops full extension of the PIP joint. The dislocation of the distal interphalangeal joint that usually occur dorsally and are commonly associated with the ulnar skin laceration. The injury is often due to the fall ball hitting the finger and causing hyperextension, like when the baseball catcher or that football game when the person that clears receive that ball or during the basketball. Reduction is achieved by traction and friction. The joint should be splinted for 3 weeks in the 10 degree of friction. And collateral ligament injuries, they are very rare in during these dislocation. And flexor tendon function must be assessed, and avulsion can occur with such injuries. The least common ulnar dislocation occurs in a situation with the fracture and usually involve damage to the extensor tendon. This is actually the mechanism of these injuries when there is a hyperextension of that distal phalanx, and that's why usually they are dislocated dorsally, and very rare they are dislocated on the other side. So that is simply the a gentle um, longitudinal traction is being applied to the distal phalanx, and then some friction is provided um, to that form pressure with thumb on the proximal aspect of the dislocated phalanx. So that friction there will make this distal phalanx its own position, and such mechanism can be used for that close reduction of this PAP dislocation. Ligament and tendon injuries of the spine of the uncollateral ligament of the first metacarpal joint, as well as the other soft tissue injuries of the fingers that will be discussed in the next session. Thank you so much.